Okay, we are going to start our lecture on chapter 32, pain. You can find this on page 1149 in your basic nursing textbook. So first of all, what is pain? Okay, so pain is the most common reason people seek medical care in the United States. Okay, it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Okay, so whatever the person says it is and is existing whenever the person says it does. Okay, pain is a very subjective experience. Okay, so pain is whatever the person says it is and wherever they say it happens at. Okay, it can have it can significantly interfere with a person's quality of life. Okay, it can affect nearly every single aspect of a person's life. For instance, severe back pain can affect a patient's job performance, engagement in social activities, sexual intimacy, sleep and rest, the ability to exercise, and the ability to perform their ADLs, right? So these factors in turn can also affect the intensity of the patient's pain, as well as the patient's response to pain. Okay, it can have very destructive effects on the body. Okay, pain can cause sleep loss, irritability, cognitive impairment, functional impairment, and immobility. And thus it is very destructive to the patient and the family. Okay, it's a multi-dimensional experience. And it can also be a warning sign of potential injury if you listen to your body well. So pain can be classified by a variety of different factors. So when you're classifying by origin, you can have cutaneous or superficial pain, which arises in the skin or the subcutaneous tissue. If you've ever touched a hot object or received a paper cut, then you've experienced superficial pain. Although this injury is superficial, it may cause significant short-term pain. Okay, and then there's deep somatic pain also. Okay, so deep somatic pain originates in the ligaments, the tendons, the nerves, the blood vessels, the bones, all of those deep, deep places. It's more localized and it can be described as achy or tender, such as a fracture or a sprain or arthritis or bone cancer. These can all cause deep, deep somatic pain. Then there's visceral pain. So visceral pain is caused by the stimulation of deep internal pain receptors and is most often experienced in the abdominal cavity, the cranium, and the thorax. Okay, so visceral pain, visceral always means organ, okay? This is not well localized and it can be described as tight or pressure or crampy type of pain. The description of the quality and the extent of the pain often serves as a strong clue to the cause. This can be something like menstrual cramps or labor pain or GI infections, things like that. Then there's radiating pain. So radiating pain starts at one origin, but extends to other locations. For instance, the pain of a severe sore throat may extend to the ears or the head, okay? Or the pain of a heartburn may radiate outward from the sternum to involve that whole upper area of the chest. Then there's referred pain. Referred pain occurs in an area that is distant from the original site. For example, the pain from a heart attack may be experienced down the left arm, through the back, and then into the jaw. Then there's phantom pain. Phantom pain is perceived to originate from an area that has been surgically removed. So patients with amputated limbs may still perceive that that limb exists and experience burning, itching, or deep pain that occurs in that area. Very interesting. And then there's psychogenic pain, which is believed to arise from the mind. So the patient perceives the pain despite the fact that no physical cause can be identified. Psychogenic pain can be just as severe as pain from a physical cause. And then if we're talking about pain by cause, okay, so nociceptive pain. This occurs when pain receptors, which are called nociceptors, when they respond to stimuli that are potentially damaging. For example, as a result of thermal, chemical, or mechanical stimuli, this kind of pain may result from trauma or surgery or inflammation. And then there's neuropathic pain. So this is complex and often chronic pain that arises when injury to one or more nerves happens from repeated transmission of pain signals. This nerve injury may originate from any of the variety of conditions, such as poorly controlled diabetes, stroke, a tumor, alcoholism, amputation, something like that, okay? So pain by duration. There's acute pain. So acute usually means short term. So this is a short duration of pain, and it generally has a rapid onset. It varies in intensity and may last up to 6 months. This type of pain is most frequently associated with injury or surgery. It's protective in that it indicates potential or actual tissue damage. Although acute pain may absorb the patient's physical and emotional energy for a short time, it is helpful for the patient to know that it generally will disappear as the tissues heal. So that's acute pain. And then there's chronic pain. So chronic pain has lasted typically 6 months or longer and often interferes with daily activities. Patients with chronic pain may experience periods of remission and exacerbation. Sometimes exacerbation means it gets worse and remission means it gets better. Okay, so it kind of comes and goes. There may be periods where it's better, periods where it's worse with chronic pain. And so unlike acute pain, chronic pain is often viewed as insignificant and may lead to withdrawal, depression, anger, frustration, and dependence. And then there's intractable pain. So this is both chronic and highly resistant to relief. So this type of pain is especially frustrating for the patient and the care provider. It should be approached with multiple methods of pain relief. And then pain by description. So pain quality may be described as sharp or dull or aching or throbbing or stabbing, burning, ripping, tingling, that kind of thing. And then pain periodicity. So it may be referred to as episodic. So does it only happen when this happens? Or intermittent, and it comes and goes? Or is it constant, where it's all the time? And then pain intensity. So this is described with a variety of terms, such as mild, distracting, moderate, severe, or intolerable. Test your knowledge. So it is most important for the nurse to understand the various ways in which pain is classified so that he or she can A, document the client's pain using accurate terms. B, be clear in communication with the physician. C, develop an effective pain management plan. Or D, educate the client thoroughly. The correct answer is C, develop an effective pain management plan. Different pain modalities are used in the treatment and management of pain and are often based on how the pain is classified. And this is the only option on this question that really puts the patient first at getting relief. So the physiology of pain, So transduction, so those nociceptors. So these become activated by perception of mechanical, thermal, or chemical stimuli. Okay, so that meaning, mechanical meaning forces that result in pressure or friction against the body. So they stretch the body's tissues, such as bleeding or swelling, right? And then other types of stimuli like surgical incisions or friction or shearing or from sliding down in bed or pressure from a mechanical device such as a cast or a brace. All of that is mechanical stimuli, okay? Then there's thermal stimuli, which results from exposure to extreme heat or cold. So if you've ever touched a hot surface or suffered an earache when outdoors on a cold day without a hat, then you've experienced thermal stimuli. And then there's chemical stimuli, which can be internal or external. So an acidic substance like lemon juice or like lemon juice on an open cut or something like that causes sudden sharp pain. That would be like a chemical stimuli. Okay, so that's the activation of those nociceptors by stimuli. And then transmission. So peripheral nerves carry that pain message to the dorsal horn of the spinal cord in a process known as transmission. So those pain messages are conducted to the spinal cord along either of those two fibers, either an A delta fiber or a C fiber. And I'll let you guys read more about that in your book. We don't really need to talk about that deep of a level, but I do encourage you to read through the anatomy and physiology review if you don't remember this from your A&P classes. And then pain perception. So this involves the recognition of interpretation of pain in the frontal cortex. Okay, how does the patient perceive the pain? Then a pain threshold. So this is the point at which the brain recognizes and defines a stimulus as pain. So the number and intensity of stimuli necessary to produce pain, as well as the duration and characteristics of the pain, vary from patient to patient. Okay, that's why we have different pain tolerances, so to speak, right? So although the pain threshold actually remains fairly constant for an individual over time, repeated experience with pain can reduce a patient's pain threshold. Okay, and then pain tolerance, like we just chatted about a little bit, is the duration or intensity of the pain that a person can endure. Varies from person to person and also from a person into different situations as well. And then pain modulation, which is a process that changes the perception of pain by either facilitating or inhibiting signals through that system. Okay, so that's where it gets a little bit complicated. Okay. So these are all, you can dig into those really deeply in your book. So factors that influence pain. So emotions such as fear, frustration, anger, helplessness, loneliness, this can all influence pain. Previous pain experience. So oftentimes patients who've had numerous painful experiences are more anxious about the prospect of experiencing pain and are more sensitive to pain. Developmental stage, the behavior people exhibit when they have pain is strongly influenced by different stages of development. We know kids are more fearful of pain than adults typically. Sociocultural factors, so beliefs about the value of expressing pain or minimizing it are often tied to culture. So as you care for clients with various backgrounds, you may notice different patterns of behavior in that way. Some patients may gain comfort from crying or moaning when they're in pain, whereas some may value silence and bravery in endurance to pain. I see a lot of this in labor and delivery with how they go through their labor pain. And then communication and cognition. So some older adults may be unable to report pain because of their cognitive impairment. So often their discomfort is evident only in nonverbal cues, such as they grimace, or maybe they blink really fast and a lot, or they withdraw. They're very, try to isolate themselves. They have labored breathing. They have an altered gait or decreased activity. Okay, maybe these are the only signs because our patient can't tell us that they're hurting. So although people with dementia might not appear to be experiencing pain, there's no evidence that they have any less pain than others, right? And so cognitively impaired adults are not less sensitive to pain, but rather they may fail to interpret sensations as painful and not as able to relay that information to us. So the body's reaction to pain. So the impact of unrelieved pain on the body system. So we'll go through this symptoms system by system. So unrelieved pain can produce harmful effects on the various body systems. So with the endocrine system, ongoing pain triggers excessive release of hormones like ACTH and cortisol, and the antidiuretic hormone and the growth hormone, catecholamines and glucagon, okay, all of that. Insulin and testosterone levels decrease with exposure to pain, and these hormones shift and activate carbohydrate, protein, and fat breakdown, then can cause hyperglycemia and poor glucose use. The inflammatory process combined with these endocrine and metabolic changes can result in weight loss, tachycardia, fever, increased respiratory rate, and even death. And then how does it affect the cardiovascular system? So unrelieved pain can lead to hypercoagulation or increased clotting. An increase in heart rate it can cause an increase in blood pressure. Pain can cause increase in cardiac workload and increase in oxygen demand. So the combination of hypercoagulation and increased cardiac workload may lead to unstable chest pain or clot formation in blood vessels that we don't want and things like that. May put them at a higher risk for heart attack. And then the musculoskeletal system. So unrelieved pain can cause impaired muscle function, fatigue, and immobility. Poorly controlled pain can prevent the patient from performing activities of daily living and engaging in physical therapy. And then patients with the respiratory system, patients in pain tend to breathe very shallowly. They limit that thoracic and abdominal movement. So this is called splinting. And when they're splinting, this reduces that air exchange with each breath and it increases inspiratory and expiratory pressure. So these changes can often lead to pneumonia and atelectasis, okay? So that's a problem. We want them to take deep breaths, that deep breathing, right? So we don't get pneumonia, right? And then genitourinary system. So unrelieved pain can cause the release of excessive amounts of catecholamines, aldosterone, ADH, cortisol, and prostaglandins. These hormones lead to decreased urinary output, urinary retention, fluid overload, hypokalemia, which is low blood potassium levels, and high blood pressure. And then the GI system, secretions and smooth muscle tone increase, and gastric emptying and motility decrease. So they may become constipated. So as you see, pain can just affect every single body system if it stays unrelieved. So when we're assessing pain, we're going to obtain a complete pain history. We're going to ask them, when was the onset of the pain? Where's the location? What factors aggravate it and what factors alleviate it? Okay, we're going to observe for nonverbal signs of pain, which can be an elevated pulse or blood pressure, can be crying and moaning, it can be grimacing or just looking like they're in pain. You can just sometimes kind of tell, right? And so a comprehensive pain assessment is going to include all of these things, right? Remember that pain is the 5th vital sign. And then we're going to assess pain using one of these scales. Okay, there's lots of different pain scales out there. The one that's on the screen, you may have seen a lot. Yeah, 1 to 10 typically is how we do it on those. So the first one being the visual analog scale. So this is the 10 centimeter horizontal line where no pain is written on the left side, worst pain imaginable on the right side. And then patients point to a location on the line and that reflects their current pain. I don't have a picture of that one on here, but it's in your book. Then there's the numerical rating scale. So this one is a line numbered from 0 to 10. 0 indicates no pain, whereas 10 indicates the worst possible pain. And then patients choose a number from 0 to 10 to show their level of pain. To use this scale, the patient must be able to count to 10. And a scale of 0 to 5 may be more helpful for more cognitively impaired patients. So you can see examples of these on this slide. Then there's also a pain scale called the simple descriptor scale. And so this is where there's a list of adjectives that describe different levels of pain intensity. And the simplest version of that scale uses words like mild, moderate, severe. And then they kind of use that to determine their pain. And then there's the Wong-Baker FACES pain rating scale. So the FACES scale uses illustrations of faces to show various levels of pain. It requires no numerical or reading skill. It was initially developed for children who are older than the age of 3. And it is also extremely useful for adults with communication issues. Test your knowledge. So the nurse is assessing the confused client and trying to determine the client's level of pain. The nurse should A, be aware that confused clients do not feel as much pain due to their confusion. Observe the client carefully for changes in behavior or vital signs. C, ask the client's family how much pain the client normally has. Or D, use only pain scales that feature numbers or faces the client can point to. We're going to observe the client carefully for changes in behavior or vital signs. That is our priority. So what are nonverbal signs of pain? So in addition to the patient's verbal report of pain, you may recognize signals that they don't actually tell you. So pay attention to the patient's physical signs and symptoms. You will see sympathetic nervous system responses if the pain is acute. So when assessing for nonverbal signs of pain, keep these following things in mind. So facial expression, posture, body position, these are all reliable indicators of the intensity of pain. So basic and common facial expressions that signal pain or lowering the brow, wincing, clenching the jaws, closing the eyelids. Guarding a painful site or maintaining a tense position is also a sign of pain. We also want to look for changes in vital signs. So generally they only last a short time. The body is seeking homeostasis or equilibrium. So after an hour or so, the vital signs typically return to baseline, even though the patient may still be in pain. So you may miss that window. So don't rely on vital signs alone. Okay, so continuous severe pain may elevate the vital signs again from time to time, but they usually rarely remain elevated. Normal vital signs do not mean that the patient is free of pain. Okay, patients may be in pain even if they don't act like they're in pain. So patients who use laughter or distraction or even sleep to cope with their pain are often undertreated. To assess pain accurately, you must ask your patient and then you must believe them. So always remember, your patient's pain is whatever they say it is. Always remember to use an interpreter if the patient speaks a different language. Ask that interpreter to explain to the patient that it's important to manage pain and that you'll be using a scale regularly to assess the pain. Have that interpreter translate or write out an explanation and directions for the pain scale so that you can refer to this when you assess your patient. With written directions, patients can usually point to a face or a numeric line and tell you about their pain when no one is present to translate. Some patients may feel like they are being bad or weak if they express pain, so that should be considered as well. Okay, those patients may become stoic or withdraw. It's important that you establish a trusting relationship with these patients. Convey your concern and acknowledge this person's pain. If the patient trusts you, they will feel free to verbalize thoughts and feelings, okay? Remember to also assess for depression. So depression is often overlooked by the patient who is in pain, especially if it's a chronic patient. And so here in this picture, you can see a patient showing nonverbal signs of pain that we're looking at. So nursing diagnoses that go along with patients who are experiencing pain. These are two NANDA approved nursing diagnoses. So acute pain, chronic pain, right? So pain management, non-pharmacological pain management, which means pain management without the use of medications, right? So cutaneous stimulation, so a TENS unit, if you've ever heard of that, transcutaneous electrical nerve stimulation. This is a battery-powered device about the size of a pager, and it's typically worn externally. And so the TENS unit consists of some electrode pads, connecting wire, and the stimulator. So these pads are directly applied to the painful area. Once activated, the unit stimulates A delta sensory fibers. And this unit can be worn intermittently, and it provides these little shocks almost that helps relieve pain to an extent. That's the TENS unit. Then there's a PENS unit. So this is percutaneous. So this combines a TENS unit with percutaneously placed, which means through the skin. So this one is a little bit more invasive. So these needle probes stimulate peripheral nerves and to relieve pain. That's a PENS unit. There's also something called a spinal cord stimulator. So this is chronic neurological pain that may be treated by surgically implanted spinal cord stimulator. It produces, so it's surgical, so it's very invasive, produces a tingling sensation that interferes with the perception of pain to the patient. There's also acupuncture. So this is the application of extremely fine needles to specific sites in the body that relieve pain. It's believed to stimulate the endogenous analgesia system. And so that is how acupuncture works. Then there's acupressure. So this stimulates specific sites in the body by using fingertips to provide firm and gentle pressure over various pressure points. This typically has a calming effect to patients, and they can be readily taught key points so that they can administer this at any time by themselves. Then massage. So by providing stimulation and relaxing the muscles, massage helps to reduce pain as well. The use of heat and cold can be very helpful in pain management. So the application of cold causes vasoconstriction, right? So when those vessels get smaller, when that happens with the application of cold, vasoconstriction, this can help prevent swelling and bleeding, okay? Now if you're using hot packs, remember that heat promotes circulation, which speeds healing. So using a hot pack causes vasodilation. So use caution with these methods, because the skin may be injured when exposed to extremes of either hot or cold. So remember, like I've said before, make sure that there's some kind of barrier around the hot or the cold pack, like a towel or a pillowcase, and make sure it's a very meticulous 15 minutes on, 15 minutes off, okay, so that the skin can have a break. Other things that you could use for pain, oral sucrose. So sometimes this is a prescription and sometimes it's not, depending on your facility. It's literally sugar water. They use this a lot for newborns who are experiencing pain. This is what they give to some of the newborns who get circumcisions as well. And then you can also use cognitive or behavioral interventions. You need to know these and you need to know the difference between these. So things like distraction, so drawing a patient's attention away from pain and focusing on something other than the pain, okay? Sequential muscle relaxation. For this, the person would sit comfortably in a group and tense up a group of muscles for 15 seconds and then relax the muscle while breathing out. Then there's also guided imagery. Auditory and imaginary processes to affect emotions and help calm and relax. Guided imagery is great for acute and chronic pain, physical and psychological pain, and they may respond to guided imagery. However, it is more effective oftentimes for chronic pain rather than acute pain. Some patients even use hypnosis or therapeutic touch. And some patients use humor, which has positive effects on a patient's physical and emotional health as well. Okay, so sorry, I got an urgent phone call, so I had to pause this and I cannot remember where I was at. So I'm going to just pick up on the last thing I remember. So anyway, humor. Humor has positive effects on a patient's physical and emotional health. For most people, laughter is positive and indicates a good mental well-being. Okay. Humor may boost the immune system as well. So that's a really great intervention as far as that cognitive, behavioral, and non-pharmacological intervention. Okay. Expressive writing, where it's the type of therapy where they can write out how they're feeling, and that can be helpful. Animal assisted therapy, that's something that's helpful as well. You may see dogs that are trained to be obedient and calm walking around hospitals, and that's something that you may see as well. Now moving on to pharmacological pain management. So this is pain management with drugs, okay? So there's a variety of different drugs that we can give for pain. So there's non-opioid analgesics. So non-opioid meaning they're not opiates, and analgesics means pain medication, pain relievers, okay? So there's NSAIDs, okay? So this includes aspirin, ibuprofen, and several different other NSAIDs as well. They act primarily in the peripheral tissues by interfering with the production of prostaglandins, okay? Prostaglandins they work on pain receptors and they're involved in inflammation. So important thing with NSAIDs is to know that they can cause GI upset and GI bleeds, and you need to take these with food. Okay, that's super important. So ibuprofen, aspirin, they need to be taken with food or milk. They cannot be taken on an empty stomach. They can cause GI upset, but they can also cause GI bleeding, gastrointestinal bleeding. Okay, so that can be a problem as well. And then acetaminophen, otherwise known as Tylenol. So this has a very little anti-inflammatory effect. However, it does have a pain relieving and a fever reducing property in it. So it has fewer side effects and is probably the safest of the non-opioid analgesics. Okay, it does not affect any kind of platelet function, rarely causes GI problems, and can be used in patients who are allergic to aspirin and other NSAIDs as well. Adjuvant analgesics. These are meds that reduce the amount of opiate the patient requires. Okay, so drugs in this category include anticonvulsants, different kinds of antidepressants, local anesthetics, topical agents, things like that. And they give them so that the patient won't require as much or as heavy of a dose of an opiate. And then finally, opiate analgesics. So opiates are natural and synthetic compounds that relieve pain. So although they vary in potency, to some degree, opiates work by finding pain receptors and they bind with them to block that pain impulse. Okay, so opiate receptors, there's a million opiate receptors. We're not going to get into that. So it's important for you to know about opiates that they have some pretty significant side effects, as we've learned a little bit already in this program. So the nurse must be prepared for these. So some of the most common side effects include constipation and nausea, okay? But there are also life-threatening side effects as well. For example, any type of opiate runs the risk of the patient developing respiratory depression, okay? It suppresses that respiratory drive. That's why before we give a pain medication, especially if it's IV, and it's going to work very quickly, we want to make sure that we are giving that, we're counting respirations before we give it, and we don't give it if the respirations are less than 12. Okay, so if the patient isn't breathing, we're going to need to support their respiratory system and give them Narcan. So if anybody's ever heard of Narcan, that is the reversal agent for an opiate. Okay, so if you notice that you give an opiate, you go back and your patient is non-responsive or their respiratory rate is 6, we're just going to give a dose of Narcan to reverse those symptoms. And then just to know that there are client-controlled analgesia pumps as well. So these are an effective and safe way to deliver opiates by IV or epidural route. And they provide excellent pain relief and give the patient a sense of control over the pain, which is nice. So the system can consist of like a programmable pump, exactly like an IV pump. And then it gives them a button, and they are able to give, it offers a continuous rate of medication through whatever route that it's giving, but then also it gives them a button where they can bolus themselves with additional medication, which has a lockout time, a lockout period, and a lockout dose. So they can't overdose themselves by pushing the button too many times. So those are really nice. So keep in mind with opiate use that repeated use can cause tolerance, and tolerance can increase the risk for overdose. Okay. Side effects of opiate use: respiratory depression, that's the big one. Also urinary retention and constipation. So when you think about opiates, I want you to think about the fact that they slow everything down. They slow your GI tract down, they slow your urinary tract down, they slow your respiratory drive. Okay. And the reversal agent is naloxone or Narcan. 2 names, same drug. Test your knowledge. So Mr. Zinabowia's chronic cancer pain has recently increased, and he asked the home health nurse what can be done. In relation to his long-acting morphine, which is the appropriate response by the nurse? A, if you take more morphine, it will not change your pain relief. B, I'll call the primary care provider and ask for an increased dose. C, the amount you are taking now is all I can give you. Or D, I'm worried if we increase your dose, then you will stop breathing. The correct answer is I will call the primary care provider and ask for an increased dose. So there is no ceiling on the analgesic effect of opiate narcotics. Patients do develop a tolerance to the effects, which often necessitates an increase in dose. So when they receive a tolerance, that means they've taken this drug for too long, their body's gotten used to the effects, and it ends up needing more to provide that same effect that it provided at a lower dose previously. And then there's chemical pain relief measures as well. So there's nerve blocks and epidural injections. Those are types of regional anesthesia. So an anesthetic agent in these types of relief measures, an anesthetic agent is injected into or around the nerve or network of nerves that supplies sensation to a specific part of the body. So nerve blocks may be used for short-term pain relief after surgical procedures or for long-term management of chronic pain. So with local anesthesia, this is the injection of anesthetics into a relatively small area of the body tissues to numb the area. So remember, local is always going to mean a smaller area, right? So these short-acting agents include lidocaine. So think about getting the numbing medicine before you get a cavity filled. Okay, that's a short-acting local anesthesia. And then there's topical anesthesia. So this involves applying a cream or an ointment that's typically containing lidocaine or benzocaine, some kind of anesthetic, directly to the skin, mucous membranes, wounds, or burns. With this, it's rapidly absorbed and provides pain relief for mild to moderate pain. And so some misconceptions related to pain management. So because pain is invisible and can be very subjective, there's a lot of misconceptions that get in the way of treating or managing pain. This slide gives examples of many of those misconceptions. So the misconception that showing pain can be a sign of weakness, or that it's a normal physical decline related to aging. It is not. It's not a normal physical decline related to aging. Some people have a no pain, no gain mentality, right? People are scared to use pain medication because they're scared they'll get addicted, or they're scared they won't be able to function. It'll make them too tired. Or healthcare workers also need to work on their own beliefs as far as as they relate to pain. It's really easy to judge something that we can't see or measure. So very few medical professionals have dealt with conditions that patients are experiencing. So if you walk a mile in someone else's shoes, you may find it very surprising. It's also important to remember that pain is our body's way of saying that something is wrong. It's an indicator to slow down or that an injury or a condition is deteriorating. For example, a knee injury or the return of cancer at some point. So we need to be aware of all of these misconceptions so that we can educate our patient. And then special nursing considerations. So managing the pain in the elderly. So pain, particularly persistent pain, is common among older adults, especially those suffering from degenerative spine conditions or arthritis or things like that. So older adults are at a great risk for under-treatment of pain because their caregivers may be reluctant to administer analgesics for fear of producing confusion, excessive sedation, drug interactions, things like that. There's also a risk of over-treatment due to a higher peak effect and a longer duration of action on these patients. So managing pain in clients with addictions as well. So addiction is a state of psychological dependence in which a person uses a drug compulsively and will engage in self-destructive behavior to obtain the drug. Many studies have shown that properly managed short-term medical use of opiate analgesic drugs is safe and rarely causes addiction, with the exception of those that have a personal family history or drug abuse or mental illness. And then the use of placebos. So this is defined as using any medication or procedure or surgery that produces an effect in a patient because of its intent and not because of the physical properties. Okay, so placebos contain inactive substances that do not provide pain relief. Okay, clearly placebos can relieve pain for some people. How they do so, not well understood, but the power of the mind and the hopefulness of this is going to help me sometimes is really helpful. And that's all we got for pain. Thank you guys.